The way that we structured this, as Dana said, is I'm going to walk through some principles of implementation science and ask Rahil some questions about how those principles have been applied in the scaling of HealthySteps, which has been a very impressive effort there. And hopefully that kind of back and forth brings up some interest from folks, and we can certainly take questions. I know we'll wait till the end to take questions, but if you have a burning question, I'm always fine to be interrupted if you are as well. Okay, wonderful. So hopefully folks are familiar with what implementation science is. So you'll see a definition up there about the study of factors that influence the full and effective use of innovation in practice. So while intervention science helps us kind of figure out what works, implementation science helps us figure out how it works. So we would be studying anything from strategies to build competency of practitioners. So some of the gifts of implementation science have been to let us know that training, no matter how well done, is not implementation, and that practitioners need a lot more support than going to training. But implementation science has also provided us with a lot of input on structures that are needed to support both scale and sustainability. And so we're going to talk about those today as we move through and thinking about this, the HealthySteps as a model. So we often think about implementation science when we think about the science to service gap, and knowing that what we know works through research trials and through the work we do to develop evidence isn't necessarily what's then used in practice or in policy. So you can see along the bottom that some of the challenges that we face are that what we do use is often not used with fidelity. We were just having a conversation about this earlier. So in that regard, we still have a lot of black box evaluations that go on because we're unclear when we have outcomes, why we have them or why we don't have them. What's used as fidelity is not sustained. So just to put a figure out there that's, I think, expresses kind of the urgency of using implementation science and thinking about these principles. So we think about the use of both evidence-based practices and evidence-based programs in human services and in early childhood contexts. The sustainability rate for those programs in the US and parts of Europe hovers around 12%. So what that means is that when we try and utilize these types of evidence-based programs in mainstream services, publicly funded services, we use them just long enough to get started, but not long enough to achieve population level change. So that figure actually a few years ago was 26%. This is coming out of the Oregon Social Learning Center, which takes a look at stages of implementation and has taken a look at some of the most widely used evidence-based practices for children in the US and also in Europe, and has found this figure. And then what's used with fidelity is not used at scale. So what this means is that we have still a lot of boutique operations where we have really well-resourced areas that are using evidence-based programming to get to better outcomes for children and families. And we could talk about this. I mean, we're going to go back and forth, but we have so much experience in the scaling, and a lot of the federal initiatives around McV, around evidence-based home visiting, around reducing teen pregnancy prevention, and what those mixed results have really looked like. So we have not realized the benefit and the equitable and improved outcomes for children and families with the evidence we do have. So we know that a lot of the methods that have historically been used to support the use of practice to get to those outcomes, when used alone, really do not give us a return on investment. So it's not to say that any of the strategies up on the screen are not important strategies, but when they're used alone, we do not get that return on investment. So I mentioned the concept of training before, that no matter how well done does not lead to effective implementation. Neither does incentivizing implementation through laws and mandates. So I do almost all of my work the last 20 years in public child welfare. So anyone who works in that will know that the Family First Act is a big issue for public systems to be facing over the next 24 months. And so while there's an incentive to be able to draw down dollars for the use of evidence to achieve better outcomes for children, systems probably are not currently set up to be able to do that, because incentivizing things certainly motivates us, but it doesn't build competency, it doesn't build structures, it doesn't build the capacity to be able to make good choices about the evidence we do use. So putting up a formula on the screen, thinking about this as more of a heuristic device that allows us to basically kind of talk through some of the principles of implementation science in hopefully a pretty easy and accessible way. So we think about what works, how it works, where and with whom it works, and being able to do all of those things well is what gets us to improved outcomes. The reason there's multiplication signs there and not addition signs is because anything times 0 is 0. So we can have the most effective practices, but if no one's using them well, we're not going to get to those outcomes. Or I walked in during the conversation earlier, if we don't have an enabling context, a supportive environment, which includes being able to draw down dollars for services, then we're not able to get to those outcomes. So what I wanted to do today with Rahil was pick one or two things from each of those blocks in the formula, just lift up a key principle from implementation science, and then ask Rahil what that looks like for HealthySteps. Okay? You think animation's clever until it's really boring, and then you're like, why do I have all that in there? So let's just forget that happened. All right. So it's like, you ever do that, and then you're up there and you're like, why do I have all these arrows, and I just want to make one point? Okay, so the first around the what works or the effective practices is yes, there's the assumption that we want to have evidence for the practices that we use. But I mentioned earlier, one of the challenges that we have is both sustaining them, and we think that part of that has to do with the concept of contextual fit. So we look at that there. It says fit is the match between the strategies and elements of an intervention, the values, needs, skills, and resources of both those who implement and those who experience. So having spent 20 years in public child welfare systems where most of our needs assessments do not include asking families what they would like, or youth who've aged out of care, what would have been helpful to them when they were in out-of-home placement, is something that it's unbelievable how that is still happening every day, and over-reliance on singular data sources to be able to kind of make the match between a program or practice. Also, part of that is we're being incentivized to use certain programs or practices, but if we have 12% sustainability rate, then this idea of contextual fit should really come up. I want to just note too that definition actually comes out of a brief release by the Assistant Secretary for Planning and Evaluation about 4 years ago, and it's the result of the mixed findings from the Obama administration on the use of evidence-based programming in teen pregnancy prevention and evidence-based home visiting. So it was this definition in 2014 was one of the first times that the federal government released a brief series on the use of evidence and actually defined the concept of fit, and spent a lot of time thinking about that. And so it was pretty groundbreaking. One of the things that we use to look at fit is a tool that's up here. I won't spend too much time on it, but I want to give Rahil a chance to talk about how they think about contextual fit when they are having discussions initially with jurisdictions that want to take on HealthySteps, and would it be a good fit for them. We look at 6 factors, hence the original name of the hexagon tool, and 3 of which are related to a program, practice, or approach itself. And they're really different factors because they're related to the approach regardless of where the approach is implemented. So an approach has evidence, right? It's demonstrated it through efficacy trials or effectiveness studies, taking a look at under what conditions and with what populations the initial evidence was grown. That's all available to us. The supports that come with a program or practice. So if I choose to to implement this program or practice, what comes with it? So if it's just training that comes with it, and we already know that that's not enough, what is the public system left carrying to ensure that they didn't waste $10 million in training people? Usability, so how well defined is a program or practice? Guidelines and different approaches like that are not very usable. So most of the work that we do, whether it's in maternal and child health or child welfare or children's mental health, we have a set of like a litmus test we look at to figure out how usable something is. I'd say about 80% of what we're approached to scale is not usable, according to what we would think about. On the blue side, this is where it comes to thinking about the fit within the setting that you want to implement. So this is not just related to the program, it's where the program will be implemented. So do we have the capacity to pull this off? Is there actually buy-in from families and practitioners that they even want this? Does it fit with current initiatives that are going on in the jurisdiction? I always say if you ask anyone who's starting something new, is this a good fit with what you're doing? They always say yes. But if you ask them, is there anything that you're currently doing that would diminish the likelihood that adding this new thing would actually get to outcomes, they will also say yes. So it's one of the few times in my life I ask a deficit-based question at all times to kind of figure that out. And then really understanding the subpopulations that we want to take a look at. Very rarely are public systems only looking at a full population of children. They're often very focused on subpopulations of children that are having particularly disadvantaged outcomes. And so those are the things that we take a look at to be able to assess contextual fit. Everything our center develops is open source. This tool is online with a complete scoring guide and a suite of resources to help communities figure out who has to be at the table to answer these questions to decide if something would be a good fit. So I wanted to ask Rahil, who's been standing up here patiently, what does HealthySteps do to support assessments of fit when you are engaging with interested sites? And what have been the biggest challenges for you in trying to scale HealthySteps as you think about context?
Thank you, Allison. I just happen to have some slides embedded in our deck to answer that question.
Unbelievable. It's like we talked before we got up here.
And thank you, Dana and John, for inviting us and putting a spotlight on this issue. I want to absolutely answer that question, but first I just want to level set a little bit and talk about what is HealthySteps. I know a lot of folks in the room are familiar. We have the Advocate HealthySteps team up there in the back who've been providing services for a long time. HealthySteps in Palm Beach County, funded by the Children's Services Council, who's here and a partner with the TMW initiative. But what is HealthySteps? The quick and dirty of what HealthySteps is an evidence-based interdisciplinary program that adds a new member to the primary care team. That person is a HealthySteps specialist, and their job is to promote nurturing parenting and healthy development for babies and toddlers. Why pediatrics? For all the reasons we've discussed this morning. You've got 12 or 13 well-child visits in the first 3 years of life, repeated access. You also have almost universal access. It's the only system we have in this country where you're pretty likely to see a child. And those children don't come on their own. They don't come on a school bus. They come with a caregiver. So the little secret of pediatrics is that's also where you find the caregivers. And finally, and I can say this as a child psychologist by training where there's an enormous amount of stigma in my field, and nobody wants to come and bring their infant or toddler to my kind of clinic. It's the most extraordinary thing. No matter the data set you look at, pediatricians are some of the most trusted messengers that parents look to. No matter the age of the parent, interestingly enough, this hasn't changed with millennial parents. They're not suddenly just going on Google to find the answers of things. They're still going to their pediatrician. So you have a almost universally accessed, positively stigmatized, repeatedly accessed system. What an extraordinary opportunity to get it right for children and families. And yet, as the pediatricians in the room will tell you, you have about 15 minutes, give or take, to do everything from fluoride to bicycle helmets to teeth to vaccinations to is the child actually growing. Oh wait, and now I have like 90 seconds left and I'm supposed to address toxic stress and parent-child relationships and parental mental health. I might need a little help with that. Thus, HealthySteps. So that's your quick and short about HealthySteps. But to Allison's first question, how do we decide sort of, is a practice or a community ready for HealthySteps? We have a national office that wants to spend our time helping new HealthySteps practices that are going to be maintained, right? We're shooting ourselves in the foot if we spend a whole lot of time getting a practice or community up to speed and then they fold in a couple of years. And how do we say yes to some people, but maybe even say no to some people, or no, not yet? That's what I like to try to say. So one of the ways we do this is we have a pretty comprehensive readiness assessment. And this readiness assessment focuses on our 8 core components of HealthySteps. You can find those at healthysteps.org, but it's the 8 essential things that you must do if you want to call yourself HealthySteps. You could do some extra things, but you got to do these 8. And they are really quickly screening for child issues, development behavior autism, screening for parental depression, screening for social determinants of health. Those are actually just 2 core components. So screening for child things and screening for family things. And then responses and follow-up to those. The 4th core component is care coordination. So being able to connect families and children to needed services. Number 5 is early literacy and STEM resources. Number 6 is positive parenting resources, right? Number 7 is short-term behavior and development consultations. So kids who just don't have red flags, they have early little light pink flags, the smallest, littlest thing going wrong, and the HealthySteps specialist jumps in and gets sleep training going. And finally, number 8, because HealthySteps is both a population-based model and a risk-stratified model, ongoing, comprehensive, co-managed well child checks with the pediatrician. So we take those 8 core components and we break them down in this readiness assessment. And just for purposes of illustration, I've taken maternal depression screening. So there's the core component itself, which is that we require regular, validated screening, not surveillance, of all new moms for maternal depression. And we ask practices when they first come to us and say, we want to be HealthySteps, where are you on this? Not doing it at all, doing it a lot, doing it a little, etc. Then there's a practice scan. So are you not only screening for maternal depression, but do you have the ability to monitor your screening rate? Do you know who should have gotten screened, who actually gotten screened? I'm not interested if you just tell me, yeah, we're screening, but do you know if you're screening the right people? Do you know if you're screening them at the right time? And then finally, a community scan. So as we all know, it's real fantastic to screen, and then what? HealthySteps can be a lot of that, and then what? But it can't be all of it, and there has to be real partnerships within the community. So you're looking at that core component, you're looking at how's the practice doing, and then you're looking at how's the community ready for it, and you're looking at this across all of those 8 core components to try to get a sense of, is this a ripe and fertile ground for HealthySteps, or is this going to be a real uphill battle? Mm-hmm. That being said, even if we found it was going to be a real uphill battle, there might be some external reason why we're going to do it anyway. Because the state says, we're going to pay for this statewide, and we're going to figure out some of these other things. So it's that balance, but we want to be really driven by our own readiness assessment.
That's great. What I was thinking about that is, I know this is just an off-the-cuff comment now, not even planned. But one of the things we've been thinking a lot about with implementation science is that one of the things it has kind of given us is this construct of readiness, right? And how critical that is to support sustainable implementation. But one of the challenges that comes with that is the inadvertent enhancement of greater disparities, because then you're only working with those who are ready. So I was wondering, because you noted sometimes you tell people not yet. So it sounded to me like you have some level of commitment to helping people get ready, and that you would use that diagnostic around readiness to kind of help support that so they could eventually be ready? I just wanted to see you want to comment on that.
Absolutely, absolutely. Up until this point, as long as someone is reaching out to us from a pediatric practice, which could be a family medicine practice, nurse practitioners, but from a place where there are well child checks going on for young children, we've never said no and forever no. We've always said, let's work for a little bit with technical assistance and get you to a place where this has more likelihood to succeed.
Yeah. Which I think is just fantastic, because I think one of the things that started to happen with some use of evidence-based programs and practices was this idea of funders only funding the ready. And so the idea of what readiness assessments are an important diagnostic that allows us to help get people ready.
Yep.
Or changes where you start with them. So I think that,
Absolutely.
So thank you so much for that. As we think about this formula, we wanted to kind of move now into kind of moving away from the what. So in that case, we were kind of talking about both evidence and fit, and using HealthySteps as an example there in terms of the actual model itself, but really thinking about how it works. And a couple things that we wanted to focus around there was the idea of it takes time. So there's my fancy animation again, but the truth is, if you look across all implementation science frameworks, and you think about the stages of implementation, you're really looking at 2 to 4 years before you would start to realize actual population change. And so, that's a big thing to talk with funders about from the beginning. And Rahil and I are involved in a collective impact initiative in Guilford County, North Carolina, which is Greensboro, and has a huge investment from Blue Meridian, and which is a kind of compilation. I see some heads nodding of funders, and the Duke Endowment is the local funder down there. And we were just thinking, it's a lot about what are the expectations, and that initiative is, a 10-year initiative, and it's really heartening when you see funders really understand that in order to bring in these types of programs and practices at scale and to sustain them requires systemic change, organizational change, collaboration, data systems that may not exist currently, and have a commitment to building those structures beforehand. So as we think about those stages of implementation, it's not so much that implementation is linear, but it is developmental. And why we like to think of the stage-based work is that if we're supporting folks to move an initiative through, we want to be able to, again, diagnostically assess where they are. So just, we've worked with a lot of, public systems that, you'll come in and they'll say, we've been doing such and such intervention or practice for 10 years, and we want to take it, across the whole state. And you might assume chronologically that they're in full implementation. So we're ready to think about efficiency and, improvements to cost. But truthfully, when you actually do the diagnostic, they're somewhere back in installation, which is they've really never put the structures in place. So if you have a little bit of staff turnover, the whole thing kind of comes tumbling down. And so we really look at, just as we would look at a child's developmental age, we look at organizationally where they are developmentally as we think about the types of support that we would want to provide. So that conversation Rahil and I were just having, that's something that would happen during a good exploration phase. And once you make a decision to move forward, the idea being that you then have to build the structures for it to work. And one of the things that happens over and over again is there are excellent programs that are not used. One of the reasons of sustainability is referrals never happen, or sticky referrals never happen, and there's really high underutilization rates. And this is one of the things we look for a lot in public systems, is we look for service utilization of new programs and practices that enter into the system that have evidence behind them. And that's something we work towards in those first couple years, is actually to get their utilization rates up. And before we even start to look at anything else. And a lot of that has to do with the structures that we build and the resources we put in place and the referral pathways that we set up for that to actually happen well. We move to initial implementation. A huge focus of that for those that do improvement science work is knowing that that we're going to have really inconsistent delivery of the service, and that we are a priori figuring out what those challenges are so that we can collect data on it. One of the biggest challenges around implementation those first couple years is that all of the changes that we make, either to our system to accommodate the new practice or to the practice itself, are reactionary. So there's actually a study that shows that 80% of the changes that we make when we're trying to roll something out in mainstream services are reacting to an issue that's come up, rather than we were a priori collecting data on that issue ahead of time so that we could establish benchmarks that we would be comfortable with and that we would keep trying to incrementally improve them. So that's usability testing is a big piece of initial implementation. Then we move to full implementation is where we would feel comfortable looking at population level outcomes. The other big piece that Rahil's going to talk about is that, part of this, as I noted, is building that infrastructure. So everything comes down to for implementation is we have all these big structures that surround us in kind of an ecological framework, but it's really the relationship between a practitioner and a child, or a practitioner and a family. That's where the outcomes happen. They happen in that moment. So absolutely everything else that's built has to be in service to that interaction. And so it's one of those things like, you hear those comments that say it was an administrative decision. Well, there should be no administrative decisions, because any decision you make should be to make the life of those who are working with children and families easier in their ability to actually achieve those outcomes. Because the intervention is that interaction, regardless of what the program practice or strategy is that you're trying to put in place. So we are always thinking about what do people need. And it's interesting, we won't go through this all today, but one of the things we like to do in larger public systems that are looking to launch something new is bring together a diverse set of stakeholders in the room that represent different sectors of the system and different levels of the system, and then go through an exercise and ask everyone in the room, give them a vignette about a certain practitioner is going to be asked to do something new, different, or more of, and say, what would that person need to do that well? And in less than 5 minutes, a room can generate 60 to 80 things. And what's really interesting is everything that gets generated is real and it's right, but we still incredibly heavily rely on guidelines and training. And it's one of the few, we could have people go through 50 things and some of that would never come up. They would talk about a lot of other deeper things. People have to know why they're changing their practice. They have to buy into it. They need to have these different types of support. And it's really interesting to hear that said by people in all different sectors, because people know what they need and how they need to support others. Typically those things kind of fall into a few buckets, the first being competency. So the idea of how we build competency, we have to be able to select a workforce that can do the work. Most of the time we're redeploying staff. We're not in ability to hire new staff, but we absolutely have to understand what they need to be able to do. So job description should change. This is a big kind of issue of mine because most of the infrastructure that we build to support new things is invisible. It's never written down. It's never documented, because you can go into any large public system, at least in my experience in mental health and child welfare, and practitioners are doing a new way of work, and I can ask one question: did job descriptions change? No. No one's job descriptions have actually changed. So therefore, the infrastructure is totally invisible. And so those are the kinds of things we look for. We need to be able to print it out, see it, touch it, talk about it, or it doesn't exist. You do need to have effective training that's skill-based. You absolutely need to have coaching. So there's really good studies that come out of public education that 95% of teachers that are trained that don't receive coaching will not implement something new in the classroom. It's flipped. 95% of them will implement it if they are coached in the classroom. So we could talk for hours as to why that is, and I'm sure everyone here can think of 10 reasons immediately as to why most adults do not change their behavior immediately.
Who, me?
Yeah, yes, I know. So the idea that we need to be able to assess fidelity, the key here too is that fidelity doesn't have to be a rigid construct. It's just the thing you're aiming for, and you need to measure it. And then you need to decide whether you want to change what you're aiming for. So there's not really a juxtaposition between fidelity and adaptation in the way that people think of it. It's just all continuous improvement. So you might as well call fidelity optimization. It's just that you have to know what it is so that you can measure it, so that you can decide whether you want to change it. And so I just wanted to say that because I think that there's sometimes some ideas about fidelity being an overly kind of rigid construct. We need to have organizational and system supports. So the systems interventions, I mean, this is for us thinking about legislatures, funding streams that can support the new work. So that's thinking about anything that has to happen in the system to allow the practitioner to be able to keep doing what she's doing. Administration, so this means whether or not you have to change policies and procedures within the delivery site to be able to accommodate the new way of work. So we just finished 5 years in New York City's public child welfare system. They have the largest increase in the use of evidence-based practices in any single child welfare jurisdiction in the country. They have gotten to population level change. It is an unbelievable example of the scaling of evidence in a public system. And they spent 2 years working with lawyers to change their policies around their standards of practice. Because some of them were policies, some of them were regulations. They were hard to change. Why did they need to change them? Because the evidence they wanted to use was misaligned with state standards for practice for all of their private service providers that get contracted to do the work. So they would be on fidelity to a model, but out of compliance with the system. And that is an incredibly common issue that service providers face. And so that story in New York is an incredibly heartening one around what that means for an administration to actually do the work it takes to change their own policies and procedures to accommodate practices that they believe in. And then the last bit there is thinking about how it is, again, that we're using data to drive our decision making and how we're setting up our public data systems to be able to provide data that is helpful to consider implementation changes that would need to happen. So that's what the framework looks like outside of the nice graphic. I noted before about things being open source. There's also a measure that we have to measure the extent to which any of these components are in place for something you're doing. And I wanted to ask Rahil to comment on this idea of building infrastructure and thinking about the HealthySteps practitioner as the lens within which you think about what needs to be built. So having you kind of first talk about how you build practitioner competency.
Sure. So if you've gone through the readiness assessment and you've made it through that, then we move on to onboarding with a lot of implementation planning. And the onboarding has about 3 phases. There's all the preparation support. So it's not just that we show up and you become HealthySteps. There's a whole lot of stuff that has to go on before that. You've got to get the funding, obviously. But you notice the second thing on there is a physician champion. We are a new member of the pediatric primary care team. I was a HealthySteps specialist at Montefiore for 8 years, so I have lived this. If I came in without the support of a physician champion into whose home I am integrating, I'm toast. But when I have that support and he's able to say to the patient, I'm so glad you brought this up, there's actually another member of our team, and she's just down the hall. And she's so much better at this than I am. She's helped so many of my patients. Do you mind if I see if she's here? That's an extraordinary, warm handoff way to present a family with a solution to what they're bringing up, right? We have our problems in HealthySteps, but lack of usage is not one of them. Yeah. We've got, there are docs in Montefiore and in other systems who refer every single infant and toddler to HealthySteps, right? And they say, well, that's what I would want for my child. Lots of implementation planning and just logistics. One thing that we make sure happens is we actually come to you to do the HealthySteps Institute. It would be a whole lot cheaper and a whole lot easier if you came to us and came to our conference room and we served you our food and you just sat there and listened to us. But that's not what this is. This is practice transformation. And if we don't come to you and meet your nursing staff, meet your front desk, meet your security staff, understand what your space constraints are, understand where your community is, then we're not going to be as effective. Then you get into that 2-day local institute that covers the what and the why and all this good stuff. And then, because training in and of itself isn't enough, even when it's 2 days long, there is follow-up. So there are 6 one-hour calls per practice that occur in that first year following training. They can be focused on ACEs screening and how to do that. They can be focused on infant mental health and what that's all about. They're catered to what the practice needs, but they're required. You don't choose whether you want those 6 TA calls. You must have those 6 TA calls. And then there's a whole lot more that comes when you're part of the network. So the training covers a lot. Like I said, it's geared to the full practice, but we also live in the real world, and we know that very few people in here are going to shut down their pediatric practice for 2 days. So we ask that the majority of the practice comes to the morning at least and understands the what and the why. And then we absolutely mandate that the physician champion and an administrative champion and a nursing champion and a front desk champion participate alongside the HealthySteps specialist in what happens next. You'll see that implementation planning again focus on those 8 core components. So there's an implementation guide that is something like 167 pages long with 11 chapters focused on those 8 core components, where the fidelity metrics are. But I like Allison's idea of calling them optimization metrics. Might be less scary to folks, but really highlighting that. And then focusing on how do you, as an early childhood developmental specialist or a mental health specialist, work in primary care. The vast majority of our HealthySteps specialists around the country are master's degree social workers, and the second most common role is doctoral level psychologists. Then, because one 2-day training, and then 6 calls isn't enough, then we're going to, show up in your inbox monthly, as our advocate team knows, and we're going to have bi-monthly webinars, monthly newsletters that aren't just newsletters. We're telling you about grant opportunities. Remember that INC, Integrated Care for Kids opportunity that Donna and Jocelyn talked about? We've been telling our sites about this for months and giving them guidance on how they might apply for it and how they might speak to their state Medicaid office. An online member connect platform, an enormous amount of resources on the website. There are the resources that you can see if you're not a HealthySteps practice, but then there's a password protected portal, say that 3 times real fast, where you can get a whole lot of resources that are for parents, for HealthySteps specialists, and for sites. At the 0 to 3 conference every year, we have a full pediatric pre-institute co-sponsored with the American Academy of Pediatrics that is a full day focused on something of issue to our practice. This year, it was on ACEs and social determinants of health screening, not just the what, but the how. And we are absolutely working on a number of online learning modules. The other questions were sort of how do we work on sustainability, right? Yep. And so I just wanted to share some of the numbers that we have showing that HealthySteps is a relatively cost-effective model. I've been counseled not to say that it's cheap, but for my money, this is a good use of money. You can have 1 full-time HealthySteps specialist in a practice that sees 2,000 children birth to 3 each year. 1 per 2,000. And they're probably going to see at least 30% of those kids on a regular basis for follow-up. The other 70% are receiving those Tier 1 universal screening services. And while the HealthySteps specialist isn't necessarily seeing those children, there are a lot of docs in our network that say, I will screen for maternal depression because that HealthySteps specialist is right down the hall. I will screen for ACEs because I know I've got the backup of HealthySteps and it's not going to derail my entire day, right? There is the one-time cost for the 2-day training and those 6 evaluation calls. How are HealthySteps sites funded? They are leveraging a variety of funding sources. The vast majority of the sites in our network leverage more than 1 funding source. Diversify your portfolio. We encourage that it's not just grants, that there is focus on health system reinvestment. So at Montefiore, where we spread HealthySteps throughout our 35,000 children birth to 3, there were 8 long, cold years of 100% grant funding. And in year 9, Montefiore said, we're convinced this is how we want to practice, we'll pay for this. So that's what I mean by system reinvestment. Then that led to the New York State Office of Mental Health saying, that seems to work pretty well in the Bronx, let's spread it around the rest of the state. So there are now more than 40 HealthySteps sites across New York State. State budget. So we have one state where HealthySteps is, where it's in the governor's budget. They said, you know what, we're pretty convinced that this is cost savings for us and that this is how we want to practice. And so we're just going to pay for these HealthySteps specialists with our governor's budget. We have sites within the Department of Defense and within the Indian Health Services. And where we are working on now is payer reimbursement. So as Donna and Jocelyn mentioned, the first 1,000 days on Medicaid work going on in New York State, really looking at a capitated way to pay for pediatric services and potentially prescribing something like HealthySteps as a way to get to that next level of payment. And you might say to yourself, well, gosh, how much more would you have to pay? You know, pennies on the dollar, it might turn out. Let's say that you were going to pay $3 per member per month for young children in your practice. If you bump that up to $5, it covers HealthySteps. $5 little dollars per member per month. So we've got at the national office a whole team of people whose only job is to make sure that sites are sustained. Because like I said, I don't want to spend that 2 days in your practice and all that time and all that sort of, and then the grant funding goes away and the practice goes away. So their full-time job is to support sites. And next, in 2 weeks, we are bringing on board our first ever full-time billing and coding specialist. So someone whose only job is to think about those 50 different Medicaid plans that somebody mentioned and the 50 different ways that you can bill for HealthySteps services within each state. We're also developing a business case. And so the way we develop this business case is to focus on short-term Medicaid cost savings. It was mentioned this morning that a lot of the interventions we do in early childhood show up in juvenile justice, or they show up in the education system. And they may actually show up in healthcare 40 years down the road, right? I don't know a lot of CFOs that are like, no problem, Rahil, 40 years is fine. I'll just budget those cost savings, you know, and whatever the year that might be, 2058, not happening. So what are some short-term cost savings we can look at? And you won't be surprised that while there are 8 that we've come up with, 3 are on the child side, but 5 are on the parent side. As Jocelyn very, very directly pointed out, there is very little point of, you know, fixing that baby who's been exposed to opioids and not fixing that family caregiving system to which that baby returns. So when you practice this sort of 2-generation care, you can look at some of these cost savings on the adult-focused interventions. A recent single state analysis conducted by the HealthySteps National Office in conjunction with Manat Health demonstrated annualized savings to Medicaid. So annualized, 1 year savings to Medicaid of up to $1,150 per family for an annual return on investment of 83%. So not that 5 to 15% that Allison showed before, but an 83% return on investment. The economists in the room could explain that much better than I could, but basically, give $1, get $1.83 back. And then the long-term cost savings that I won't spend a lot of time on because folks know these, but essentially the direct relationship between what happens in early childhood and long-term health outcomes, school readiness, juvenile justice, and the like. To the fidelity question, we do have annual site reporting focused on fidelity monitoring. So maybe that sort of gets to what you're saying. We give our existing sites 5 years to get up to fidelity because we just rolled these out this summer, and our new sites 3 years because it's a lot easier to turn around a ship that just went out to sea rather than one that's way out in the sea. So I'll pass it back over to Allison, but also focus on the fact that we do have a few outcome pilot sites right now in Illinois, actually, Advocate, and New York and Colorado, focusing on deepening our evidence base. There was a randomized control trial published in the early 90s, or done in the early 90s and published in 2003 in JAMA, but that was a minute ago. So let's update our evidence base and really dive deeper on some things we know are critical to healthcare today.
It's interesting. I had in when you had that the slide up there about the kind of child and the adult-focused interventions. I was thinking what a great 2-gen approach that is. And I hadn't really thought of HealthySteps as a 2-gen model before, but as you were talking about it, it makes so much sense. And we've had so much trouble realizing outcomes on 2-generation approaches in this country because they're usually totally misaligned.
Right.
They're like, kids are in early Head Start, and then mom's over here getting, financial coaching, but it's like, it's not the same kind of thing. So
right.
yeah.
It's that crazy thing we do in this country where we separate the head from the rest of the body, we separate the parent from the child.
Yeah.
This is a dyad living in real life, and what happens to one impacts the other, and so why not intervene in the place where they are, which is the pediatric setting?
No, and it's so important because I do think these challenges with yielding child outcomes in 2-gen approaches is there's been a bit of resistance to continue to fund 2-gen work. So anyway, this gives me good talking points around that with funders, so that's really helpful. That is just such a fantastic example, everything you just went through, around the sustainability piece. I love that you're hiring a billing coding person.
Me too.
Because this is just what happens, we have so many, services that enter into a system and they're kind of incubated. They're kept, they're not part of everything. They're kind of launched by a strategic initiatives division or something like that, often in public systems, and they never become fully integrated. And one of the reasons is because they're not reimbursable outside of the original grant funding. And so this kind of, work that you guys are doing is so groundbreaking and is like that the key to how you work a system. How you think about those 50 codes and how it is to keep delivering the services. So that's just fantastic. We're just going to move it. Are you guys doing okay? It's like the home stretch. Yeah, 7 minutes we're told. So even if we didn't want it to be the home stretch, it is. And I think we're gonna come into that. So I know it's like right before your lunch and all these things. So hopefully we're kind of keeping you going here. So just a few more points. When we think about this, where and with whom it works. For us, this really is that supportive environment that has to be built for something to be sustained. And Rahil already started talking about that with having the physician champion. And so we'll talk a little bit more about that. But a huge key to scaling is having a team-based approach. So there's really nice empirical evidence around the importance of implementation teams in terms of kind of time to implementation, sustainability of implementation. A lot of that work's been done in public education, where about 10 years ago, there was a real movement to move away from this kind of solo hero or solo leader model, meaning like a superintendent can kind of, make really good choices kind of in a vacuum. And the idea of what it means to bring together stakeholders to be able to make good choices around implementation and to address challenges. And the reason that is because if you're implementing something that is complicated and you're implementing it in a complex system, the idea that just a couple people would have all the solutions seems a little silly, right? So, but this idea of using teams is really hard to do actually in public systems that are incredibly siloed. And I heard that in the first, someone said put a Starbucks in the middle and everyone would come. And I love that because it's actually probably true. But we struggle a lot with building teams, but the piece that's so important is there has to be an architecture for scaling, right? You have to have something to be able to latch onto at each level of the system. So like in our work in K through 12 education, or Head Start's another good example, they're actually kind of hierarchical vertical systems. So they're a bit easier to do scaling on, right? Because you can do a state education system, regional, district, school. Head Start, you can work in the 12 regions and kind of then roll out to program level. Child care is harder because it's not set up that way. But the idea of how it is you build out a teaming structure, because what you want is you don't want to just do more of something at one level of the system. You need to build capacity at the level above to be able to support the level below it. If you're not doing that, so scaling is about ratios. And so if you don't have that kind of buy-in at each level of the system, when you have turnover at teacher level or nurse level, the whole thing falls apart. And so many of our systems, our turnover rates are 60% a year. So the idea that we would be so focused on, again, training alone and practitioners is really just not smart. It doesn't work. And so we essentially, I'm not saying that much about the structure of teams on this slide, but we have a lot of tools available to help people build out teaming structures to support scale. Gave a couple examples of what this often looks like for us, but the typical thing that you want to have happen if you're doing kind of multiple service change, this is a child welfare example, but you need to have people that are overlapping on each of those teams. And that's a huge key. So we spend a lot of time building out our teaming structures and figuring out our feedback loops. It is very processy. People hate it, especially in the United States. Like you could go to Norway and this is so easy to do, but here people are like, what? Like, let's just do it. You know what I mean? And you're like, no, let's not just do it because it's not gonna work out too well. Because the truth is, unless we have an organized structure and every team that's set up has a memorandum of understanding about how they interact with the team above or below it, or on the sides of it, you really don't get any sort of cohesive communication or change. And when there's not formal communication, it gets replaced by something, which is informal communication. And so if you're not controlling communication, people are talking anyway. And so this is the kind of thing that when we go into a large system, a state system, or a small country, we move into teaming immediately. It's a big piece of work that we do. And what I'm going to do is just move through this next piece and have you come back to teams and communication.
Deal?
Yeah, let's do that. Because as I'm on communication, the key thing is we set up these communication protocols. They can be like literally if we have 6 teams, we give them each a number and we talk about who needs to be communicating about what and how often and who doesn't need to be communicating about certain things. We do the flip of everything. So everyone knows if they're experiencing issue at service delivery site level, hospital level, when does that have to move up to a leadership team and when does it not? So we talk a lot with service systems about when you set up teams that you have to have delegated authority because people who sit on teams have to be able to make decisions even if they don't supervise the other people that they're asking to do things of. These are all the structural issues that make change hard. When people sit on teams and they're really excited for the work, but they actually don't supervise the people that need to do something differently. And so those are the kinds of things that if you come into the system, you have to get very high level buy-in immediately to write delegated authority memos and to start the work moving. I mean, this is the whole kind of structural stuff behind scaling that needs to happen. So I'll go back and you can kind of touch base on that.
Very quickly. Yeah. I think the idea that your implementation team, as I mentioned, has to have at least the physician champion, the HealthySteps specialist, the administrative manager. This red thing, that's from that readiness assessment, remember? So this is one of the core components that we're going to make sure, do you have this? And we give some flexibility around it. Then we're going to make you a sustainability roadmap. Right? For your state, yes, we do have 50 different state Medicaid offices that have 50 different ways of paying for this, but we're going to help you look at your state Medicaid agency opportunities and Medicaid managed care and the like. So always thinking about that level above, yes. Right? And not just thinking about our wonderful public servants, our state Medicaid directors, because did you know how often they turn over? Approximately every 18 to 19 months. And so if it takes 2 years to kind of develop a relationship and get something going, they're out of here.
Yes.
So do you go to their staff folks who are a little bit more likely to stay?
Mm-hmm. Okay, that's great. I think we're good.
I would say the only thing I would end with, is this. And I was asked to put this slide in at the very end. And I think it's a great way for us to end. So in 1995, back in the day, there were 2 HealthySteps sites. And then there was this wonderful national multi-site, multi-state randomized control trial with real fidelity to the model, like tight fidelity, just how you want it to be, with also then some quasi-experimental things going on the side and all these sort of things going on, right? And then, between about 2003 and 2015, I like to call it the Wild West of HealthySteps. There was a whole lot going on, and it didn't necessarily all look like the other things going on. Not a lot of quality checks, no fidelity. Those fidelity metrics, we rolled those out this summer, right? Yeah. I started in February, and the HealthySteps folks in the network are probably like, God, it was better before she got there, because we rolled out fidelity metrics and these core components and the implementation guide. Because you see what happened between 2015 and 2018, while we were working on all this, we doubled in size almost. How frightening is that? That before all this was ready to go, and before we had the implementation guide ready and the fidelity metrics, we almost doubled in size. So now we're looking at retrofitting to some extent and helping folks get there. But I thought this was actually a really good suggestion to include this slide, because if we focus too much on fidelity, we stay with those 2 sites in 1995. And if we don't focus enough on fidelity, we get that Wild West between 2003-ish and 2015. If you've seen one pediatric practice in this country, you've seen one pediatric practice in this country. And we, by definition, have to be flexible enough that we can effectively integrate into the pediatric practice and deliver an enhanced service to the young children and families in the practice, but have fidelity to the model enough that I can say that HealthySteps at Advocate looks somewhat like HealthySteps in Palm Beach County, which looks somewhat like HealthySteps in New York. And that is the absolute goal. We're right now in 20 states, Puerto Rico and Washington, D.C., and our goal by 2032 is to be in all 50 states and serve 1 million children, mostly children on Medicaid, every year. So to do that well, it's going to be this tension and this dance between fidelity and flexibility, but over-reliance on one or the other, and we're going to shoot ourselves in the foot.
Yeah.
So you'll be happy to know that Allison is one of a few external advisors on our external advisory group on exactly this issue. We take this really seriously and want to try to get it right. We're going to make mistakes along the way, and I hereby promise that we will be as public as we can be about those mistakes. Because it's gonna take a whole network to really focus on getting that balance right between fidelity and flexibility.
And it's such a huge question, and the tension between the integrity and the scale. So, you could do like a train the trainer model, which is just totally focused on scale, right? You just keep rolling it out. Or you could have those kind of approaches where, you have to be certified to do it, and you have to have 75 mentors for 10 years to get certified. And I can name a few early childhood models where that's the case, and they're great models, but they're not
serving
scalable.
1 million kids, right?
And it's this idea, too, around the fidelity piece. It's just the last little point is that, honestly, what we started to come to accept when we overly focused on fidelity was this concept of voltage drop, that your effect sizes continue to decrease. Because as you said in those first 2 studies or sites, like everything was held so tightly and you got to nail fidelity. If we think about scale as replicating with fidelity, what happens is you automatically get voltage drop because you're not nimble enough to respond to the issues. And so there's this concept that both sustainability and scale are dynamic processes, which is why fidelity is important, but probably better framed through an optimization perspective than like having to look just like those first 2 sites.
Right.
Because voltage drop it's not necessary, actually, if you do use data for continuous improvement.
There are about 6 million children birth to 3 on Medicaid in this country right now, give or take, and we're not going to get there, right?
Yeah,
if
exactly.
we keep it this close, but let's get it right. So I think that is time to turn it back over to Dana and turn it over to you guys for questions. So thank you.
Thank you.
Thank you for a wonderful interactive panel. That was by definition interactive. So at this point, we'd like to open up the questions for about 15 minutes prior to lunch.
Hi, I'm Raquel Jeffers from the Nicholson Foundation in New Jersey. It's a local foundation in the state. Thank you so much for your presentation. I found it just incredible. And I was wondering if you were to give advice, let's say, to a foundation in a state about bringing HealthySteps into a state, how would you suggest they start?
Thank you for the opportunity, Raquel. I will share with you a real live example. So the Robin Hood Foundation approached us in New York and said, we're interested in scaling HealthySteps throughout the 300 plus federally qualified health centers in New York City. All right. So the response was not just, great, you know, here's what it'll take for salary and benefits and training and some EMR, you know, work and the like. The response was, fantastic. Let's think about that and pull in state Medicaid. Let's pull in our wise friends at places like Manat Health. And let's simultaneously create the business case for HealthySteps in New York alongside the investment in expanding the footprint. Federally qualified health centers in New York work really differently than non-federally qualified health centers in New York. That's not so much the case in every state, but in New York that was quite true. So we're looking at two business cases, one just for the FQHCs in the state. To build an effective business case, you need that time and energy spent with the experts who know how to do that, but you also need a HealthySteps footprint to be generating the sort of data points that you need to feed into the business case. So from where I sit, I think that's the most effective philanthropic way to intervene. I am not a philanthropist, but I assume that you're not interested in hanging around for 20 years in one practice. And so to be able to start from the beginning to build that sustainability piece and use the seed money that you provide, it's so interesting to me that you said it takes about 2 to 4 years for something to get baked in.
Yeah.
I'd never heard that, but we always sort of felt like we used 18 to 24 months. And we knew that you were baked into the practice when someone asked you for money for the baby shower.
Right.
Right? Like that's how you know you're in. They think you're in this practice.
Yes.
And it takes about that long, interestingly enough, in our FQHCs in New York to be cost neutral. So the reimbursement that's coming in pays for the salary and benefits. Thank you.
Hi, I'm Judy Carta from the Bridging the Word Gap Research Network based at the University of Kansas. And I'd like to go back. First, thank you for a great presentation and so many ideas that I'm going back with. But I'd like to go back to the last issue that you were discussing about fidelity and scalability, because I think it's an issue that so many of us who are intervention developers struggle with as we try to go to scale. And so the question is, how often when we try to address that question, do we really have a handle on what the active ingredients of the intervention are so that we know what's really essential when we go to scale? And so do we identify our core components that are most essential for going to scale based on research, or are they coming from our guts?
I can answer that just on the HealthySteps example, but I'm sure Allison has a broader example. And John asked me this very question last night, like, how did we come up with these 8 core components? Pull them out of a hat, you know, what happened? So what happened was that in 2016, we partnered with an external evaluator, the James Bell Associates, who were working with MDRC, and did an evaluation study of our whole network. So in 2016, maybe there were 80 or so practices out there running HealthySteps, and they asked all 80 practices, what are you doing? What do you call HealthySteps, right? And looked at, all right, these are the 8 most common core components that seem to be, from all these interviews with folks, the drivers of getting an effect here. But it was a pretty comprehensive, year-long national survey of what was actually going on out there to distill into these 8 core components. That doesn't mean that some places weren't doing additional things that they felt really, really attached to. For example, all of our HealthySteps sites in Arizona, the HealthySteps specialists are also lactation consultants. And they had gone through and gotten that training and were providing those services, and they felt like that was really key to their work. And they were the only ones doing that. So we're happy for you to add that on. You can add on a whole bunch of things, but you got to do those 8 that we saw through that study were the drivers across the nation of what was really happening.
No, it's true. Just to tack onto that, and then to just mention kind of when you're first starting out. But, well, first, I mean, most fidelity checklists have taken about 20 to 25 years to develop. So, because in order to call something fidelity, I'm thinking of certain models like nurse-family partnership or something, right, which has had like 60 RCTs. Not that I'm saying we'll have to do 60 RCTs, but the idea being that to say something's a fidelity checklist means that you know that a certain dosage of X has been demonstrated to yield Y, right? And you've been able to demonstrate that in a research design of some sort. It takes a really long time to do that. And so HealthySteps has been around a long time. It's the ability to identify these 8 core components. And over time, you might want to do variations on those 8 core components and say, what if I remove 2 of these that feel super burdensome? You know, can I still get those outcomes, right? Can I pull back dosage? Can components 1 through 3 be done more quickly? Like, those are the kinds of things that some interventions in this country have had the luxury of doing, like an NFP. You know, most don't, right? And I'm thinking for child welfare, like multisystemic therapy. I mean, there's some that really have these kind of fidelity checklists. Other than that, I mean, the fidelity components are still emerging probably for a lot of people, and you're kind of, I think what Rahil said that they did is exactly what you want to do, is you want to kind of figure out what are people doing, what from both data and people's actual experience seems to have this intended benefit, and we start there because it's the best place to start. But when we work with programs to build, or communities to build their own evidence, so like a promising program that they have. So we have a 5-step methodology we use that involves a systematic scoping review so that we actually bring in research evidence, but we interview everyone from families to practitioners to leaders to basically say, what's your successful narrative? I was just doing a core components analysis last night on a spreadsheet of 20 million interviews that have been conducted in a system to try and figure out a practice approach for children in court-ordered supervision. Like, what is it that seems to be what we want to train on and coach on? And all we're going to get from that is an initial set of core components. A fidelity checklist would be something that would need to emerge over pulling things back and seeing, you know what I mean, and just kind of seeing that. So it takes some time. It's incremental. But I think you start in the best place possible, which is where are you getting results and why do you think you're getting them? And why not start there?
And what feels possible.
Yes, and what feels
versus
possible.
super burdensome. So in the original
Yes.
HealthySteps RCT, home visits were required. Well, home visits takes you to a whole different cost per family. It takes you to a whole different resource level, and it felt super burdensome to families and to providers, and families. Not all families want a home visit, right? We have this sort of thought in our mind: let's just give everybody home visiting. Well, not everybody wants home visiting.
And then the thing is then for HealthySteps to know if they pull back the home visit,
does it still work?
do they still get intended benefit? And say they don't get all the intended benefit, just making that up, but they get big ticket ones on that, because a lot of it's the return on investment with scaling, right? So maybe there's some benefit that you can't get without that home visit. I'm just making this up, I have no idea. But I really don't, and maybe you could get all of them. But maybe the benefits you are getting are good enough, worth it and scalable. So those are the nuanced choices that are made that need to be talked about and are diminished so much when we think about a checklist that you know what I mean, that everyone would have to adhere to. I'm sure there'll be times where HealthySteps enters into a jurisdiction that those 8 components have to look a little different or something, and you'll go for it. And you'll see what that looks like.
Yep.
You know, because that's the nature of scale. The key is just to document it and understand if it had its intended benefit, not to just kind of hope, which is honestly what most of us do. Yeah.
We have time for 2 questions if they're really brief, and I know you had your hand.
That's if our answers are really brief.
Yeah. I'll try.
Yeah, I won't say anything because I'm not
Okay,
a
great.
great
That's
person,
helpful.
so I'm done.
Am I on? Oh, okay, great. Anna Riley with a community-based organization that fits right about 1995 in your slide, 2 sites, RCT. I'd like to know how you leveraged your RCT findings to inform your expansion, and how else you used your RCT. What impact did it have in kind of the direction you ultimately ended up?
Great question, thank you. And to be fair, I wasn't around doing it in 1995. I mean, I was around, trust me, but I wasn't doing HealthySteps. You know, it sounds flippant, but publishing it in JAMA was a pretty good first start. We became one of the McVie evidence-based practices, which is another real good start. But then remember I told you we stopped requiring home visits. So then we weren't. All right, good.
So you were home visiting program without home visits.
Yeah, so then we're no longer a McVie, home visiting program. I think that going back to what Allison said earlier about, I forget what you called it, sort of an uptake problem or something like that. We have lots of problems in HealthySteps, the Wild West and all that sort of stuff. Uptake is not a problem. When I ran our program at Montefiore and we had a grant funder come, and they asked me, what's your dropout rate? And I went white. I didn't know. And I knew our numbers. I knew this, that, and the other. I didn't know. And I really kind of let loose on my team afterwards. How could you guys let me go in there and not know the dropout rate and what's wrong with you? And I looked like an idiot. And they said, Rahil,
You don't have one.
there was that one family who moved to Pennsylvania. Pennsylvania is the promised land if you live in the Bronx. It's all going to get better in Pennsylvania, right? And so, there is something about the community speaking loud with their feet about what they need and what they want. And if the community speaks loud enough and you've got some data that you can leverage and get out there and align, something Allison said early on, I always say to folks, what are the quality metrics that your state cares about? What are the things they're already driving for? And the things they already hold out as problem areas. Ohio might have a problem with, X, and Illinois has a problem with Y. How can you align your program with helping them to answer something that they're already thinking about, right? Rather than come in, well, this is what I do and this is what I change. How can I align with what are the quality metrics that New York State already cares about?
I actually think, Rahil, I think you're mentioning the low attrition rate actually speaks to why leveraging the healthcare. I mean, it speaks to the power of your program, but it also speaks to the fact that children and families come to the healthcare system.
100%, Dana.
you
We
meet them where
borrow
they
from
are.
that trust in the physician. We borrow from the beauty of the healthcare system, and that's why it works.
Yeah.
A lot of attrition in children's mental health clinics.
Yeah.
Jocelyn Geyer with Manette. First, thank you so much. That was totally wonderful presentation, although it left me with spikes of anxiety about the lack of systematic implementation that I'm doing with some various states. So actually, on that note, I'm wondering, part of why we don't do as systematic an approach as you would suggest is oftentimes state policymakers and federal policymakers push back pretty hard on a 2 to 4 year ramp up. They want to see return on investments much more quickly. And so I'm wondering what strategic advice you have on working with the stakeholders that expect and want to see much more rapid return on investment.
Yeah, which I think is everybody, and you could talk about that too. We have some kind of policy maker slides that we use a lot, or talking points, and for us, we always establish metrics that they're interested in that we can demonstrate early. So whether that's uptake or that kind of thing, there's always metrics that there is some level of interest in that we can achieve early, and then we always show. And not in like a complicated logic model, but something super clear, like just a really clear flow chart that's going to yield, the next set of outcomes. and here are the timeframes for each one. And usually if we do that, folks can feel super comforted by that. So we always pick a set of metrics that we can look at early, if possible, and we always show something incredibly simple that allows them to see. The other thing is we have tons of really scary data on lots of investments that have never worked. And so we don't like to go in that direction, but if needed, we would pull that out and say, let's talk about all the other big investments that have been made. It's amazing. We're just doing some work now with Pew Charitable Trust, and they go in and do evidence scans in states just to see what programs or practices are being utilized that involve evidence, and it's unbelievable how low that is. Yeah. So yeah, and then it's also finding your policy, the one or two that are champions. So trying to identify someone early on that you feel like you could get some buy-in from and work from there.
And I would say, and again, to that point, so like some early wins, and some early wins that may not have been, to the question before, may not have been you're even top 1 through 3 of what you thought you were achieving. It's like number 6 of what you were achieving, but it's real high on their on their list. So the example I always use in HealthySteps is there's a HEDIS metric that you should have 6 well child visits by age 15 months. That's like low, it's not the number one thing I think we're trying to impact. We're trying to impact parent-child relationships. But if I can deliver you 6 well child visits by 15 months, and that helps sort of establish the buy-in, then I will do that.
Yeah.
Wonderful. Well, thank you so much.
Thank you.